Thank you. I'd like to thank the organizers and the organization for inviting us and for bringing together a group of individuals around the issue of improving safe and effective use of medications, both for women and in pregnancy. And I've changed a little bit the title of my presentation to focus on the issue of real life, in part because often those of us who are engaged in practice, providing care for women or whether they're pregnant or not, are often troubled by the fact that data on appropriate dosing, characterization of effectiveness of treatment, and safety-related issues is not well characterized. Certainly there have been attempts over the past decade or so to improve that by broadening the inclusion of women in clinical trials and by asking for evidence-based information about dosing, safety, and effectiveness, both for the mother, the placenta, and the fetus across the course of pregnancy. But we're still struggling in many cases with issues related to how to best treat individuals during pregnancy. And comparing treatment of men and women. So what I hope to do this afternoon is provide an overview that focuses on sex and gender differences in drug disposition, knowing that I'll be followed by Professor Ibert, who will talk a lot about the impact of pregnancy. So I'm going to be looking at sex differences in a way to try to set the platform or the stage for thinking about what's the pharmacological status of women, and then how does pregnancy change that? And that, I think, will be a strong part of what Mary is talking about. In the course of going through these sex and gender differences, I'm going to provide a fairly broad summary of the literature, but then I'm going to talk with you about some experiments that we've done in collaboration with colleagues at SimSip, where we ask, in simulated humans, how do men and women differ? And if we were to design studies to better demonstrate the differences between men and women, how might we want to think about changing those study designs? And then I'm going to spend some time talking about characterizing signals for adverse events in real-world settings. And this is a unique partnership that we have with Risk Sciences and the University of Ottawa with a company in the United States called Cerner. For those of you that are in the US, you may be familiar with Cerner. It's one of the second or third largest electronic health record companies in the US. And it gives us the opportunity to essentially look over the shoulder of practitioners and ask, how do they make choices about treatment of specific diseases? And how do those choices influence what they do? And can we learn from that how disease comorbidities and combination medical therapies influence the development of safety signals? And in that context, can we even think about being able to separate safety signals that emerge in men compared to women? And give you some examples for the ways that we're doing that. I'd like to start with just a little quote. Professor Schwartz, a member of ASPET and who's written extensively on sex differences, has a marvelous little quote, or at least I think is a marvelous little quote, in the first issue of Marion Legato's Principles of Gender-Specific Medicine. She indicates that women make up more than half the population of the world. However, treatment fills far less than half of the medical literature, pointing out the disparity in terms of what we know and how that's shared. A little bit of a case study to start us out. For those of you that were watching the New York Times earlier this year, there was a flurry of, and other publications, a flurry of interest around an FDA ruling that changed the recommended initial dose of zolpidem. And Janine Clayton, the director of the Office of Research on Women's Health, says it's not just about that particular drug, zolpidem. There are a lot of sex differences for a lot of drugs, some of which are well known and some of which are not well recognized. And I think you'll see that as we go through the literature, that there are times when I know the tools that we have, how we can think about asking questions about pharmacokinetics and pharmacodynamics can be done in a better way in our looking at men and women, but we're still not doing it yet. And so there are gaps that are frustrating from a clinical and scientific perspective. Well, what did the FDA use to change their recommended initial dose? And the thing that I find interesting is that part of the data that they're basing this change on was actually in the literature for more than a decade before the change took place. The FDA recommends that the bedtime dose be lowered in women because new data shows that blood levels are high enough to impair activities that require alertness, like driving. So the scenario is zolpidem to help you sleep. Take it when you go to bed. Get up in the morning. Are you still going to be alert enough to get the kids organized, lunches packed, car packed, and take the kids to school and drive to your job without an accident? And what they're suggesting here is that the new data that they have suggests that the answer to that question is no. So the recommended dose was halved. So again, given that we knew the pharmacokinetic information, the new part may be the accident rate. But you know, here's something that we could have thought about and potentially responded to a decade ago. As I think about this, I think about it from the context of personalized medicine. Over the past 2 decades, there's been a lot of attention on making sure that the diagnosis that we give is appropriate for the individual that's in front of us, that the therapeutic strategies we use meet that individual's need, both for the diagnosis and other factors that they're dealing with. So how do we think about the role of sex in disease risks and processes? We know that men and women are different in a range of ways. How do those sex-based differences influence the way that we should think about treatment options or treatment goals? And then in the course of therapy, we don't just treat and walk away. We have a set of intermediate steps along the course of treatment which encourage us to ask, is this treatment working? Is it working as effectively as we think it should? And what are the adverse events, serious or common, that can occur across the course of this treatment, and are we monitoring for those? So then, how do we think about sex, pregnancy, or gender influences on pharmacokinetics and pharmacodynamics? Well, we know that men and women differ. This is taken from the ICRP publication, but it's NHANES data from the US, comparing body mass between men and women. And what I hope you'll understand at the end of this afternoon session is that we should think more broadly about differences between men and women as something as simple as, it can't be described as simple as, you know, women are small men, or men are just big women. So it's much more than size, although size can play a role. And even endocrinological events occur differently across men and women, or boys and girls. So the onset of puberty occurs at different ages and produces different body phenotypes and body compositions in males and females. And that's also shown in terms of height growth. So when does the growth spurt begin, and how does it differ in terms of consequence in men and women, or males and females? All of these, in part, come together to create the anatomic, physiologic, and biochemical and endocrine differences between men and women that can have an influence on drug disposition and response. And here, again from the ICRP publication, some of the kinds of parameters that get folded into physiologically based or perhaps less rigorous pharmacokinetic models that we can use to begin to compare males and females. Well, an example that many of you are familiar with, how do men and women differ in terms of response to alcohol consumption? This is just one example where the authors, Backwin and others, attempted to replicate alcohol consumption in a social setting with a light meal and then follow blood alcohol concentrations. And the dotted red line that's horizontal across the top is the breath alcohol concentration that is frequently the legal limit of alcohol in European countries. And what you can see is each individual that took part in the study is a blue dot. So at 15 minutes after the alcohol consumption was ended, half of the females were above the legal limit, and essentially none of the males. And then they continued with differences in elimination, which aren't well described on the slide, but this just points out that even in common exposures, there are differences in the way that men and women respond. So I'm going to use this cartoon or diagram across the course of the rest of the presentation. It just gives me a way of organizing my thoughts around some of the steps that we'll talk about. So absorption, distribution, and then metabolism and elimination. And I'll comment briefly on each of these across the talk. But I'm going to start with what we always watch for when we're using a therapeutic product, which is adverse reactions. And one of the questions would be, if we're going to give attention to sex differences, if we're going to focus our attention on sex differences, is there any reason to think, what are the kinds of things that we should be watching for? Well, one might be adverse events. Certainly, safety has driven a lot of regulatory activity, although I guess I'd have to just take a step aside and say, when I use a medication, I certainly am worried about adverse events. But foremost, I'm interested in making sure that that drug does what I want it to do in terms of treating the disease. So while I'm going to give some attention to adverse consequences over the next few minutes, we shouldn't lose sight of the fact that we need to make certain that the drug is doing effectively what it's intended to do in terms of the treatment strategy and the disease context that we chose that drug to work in the care of our patient. Well, Tom Moore and his colleagues have been following adverse events reported to the FDA for many years. And several years ago, they looked at the types of adverse events and the differences in reporting between men and women. And they observed that they were more likely to see adverse events reporting by women than men. And that's actually been replicated in a Canadian review of adverse events by Tran et al., who indicated that 70% of the adverse events reported in Canada were reported by women. This is Tom Moore's data, and the thing that is interesting about this is that he compares the rate of reporting and sex differences in reporting of adverse events to the US FDA with IMS outpatient prescription data. So over the period 1998 to 2005, the rate of outpatient prescription rose from 2.7 to 3.8 billion prescriptions per year. And the rate of serious adverse events reported to the FDA adverse event reporting system increased from 35,000 to 90,000. So adverse events were actually increasing at a rate that's roughly fourfold faster than the rate of increase of outpatient prescriptions. Now, there are a host of questions that lie behind that kind of information, like the nature of the drug, the way that the drug was used, and so on. But the thing, again, that I think was interesting was the difference in reporting between men and women. Well, if adverse events are a concern, one of the questions we might ask is, can we anticipate them? Are there things that we should look for that would suggest that we need to watch this patient more closely for adverse events? This was a study that was done in Europe looking at risk factors that could be identified on admission to hospital that were associated with adverse events in the course of care in the hospital. So they evaluated 900 patients, and among that group of 900 patients, more than a third had at least one adverse drug reaction. And then they asked, what were the factors that predicted whether that patient after admission would have an adverse event? And there were a series of clinical signs, temperature, erythrocyte count, and thrombocyte count, that were to some extent predictors. And then the number of drugs. Well, of course, we know that drug-drug interactions are common causes of adverse events. But one of the strongest predictors was female sex. So a take-home message from this kind of an analysis suggests that being admitted to the hospital, a strong risk factor for adverse events in hospital is being female. So the question again is, what's behind that? Another study that was done in the U.S. in Salt Lake City at the Intermountain Health Group also looked at patient, drug, and patient type risk factors and observed that one of the strongest risk factors on a patient perspective for adverse events in patient was female sex. Clearly others like renal function, comorbidities, concomitant medications, and so on, as well as root, play a role. But again, the thing I think is intriguing is this preponderance of women. And when they broke the risk factors down by drug class, so the majority, 60% of the adverse drug reactions were reported for analgesics, and within that group, there's about a 70% excess of women in terms of adverse event, and so on. And you can see it as it goes down, that essentially all of the groups, perhaps with the exception of the anti-infectives, have a substantially greater risk for adverse events among women compared to men, and that's true for the severe adverse events as well. So why are we seeing these sex differences? Some have argued that part of the reason is more frequent use of prescription medication among women. Tran and others in Canada suggested that in general women were using more medications than men, so drug-drug interactions. Women see physicians more often. I guess seeing a physician is a risk factor for an adverse event. But don't forget that our understanding of toxicology has demonstrated over the past many decades that male and female experimental animals do not behave the same way to xenobiotics. So if we've known for some time that toxicological mechanisms are sex dependent, then it shouldn't surprise us that when we start to tease out why women are more likely to have adverse events than men, that there may be some underlying biological mechanisms that support that difference. So again, I'm going to talk briefly about pharmacokinetic and pharmacodynamic factors, not so much about drug-drug interactions. So let's begin with administration, absorption, bioavailability. This is one example from a bioequivalent study that was done in Spain several years ago, looking at two different formulations of amlodipine, a common calcium channel blocker or antihypertensive. The red dotted line shows the blood concentration over time in females, and the blue in males. And I don't know, does this red dot show, or am I guess I can't see it on the slide, but maybe I can use this. Well, is it? Thank you. So since both men and women were given the same dose, and since we know that in general men are heavier than women, the weight-adjusted dose is greater in women than men, not a surprise. But that then suggests and is replicated or validated by the exposure based on the area under the concentration curve, greater in women than men, and the maximum concentration greater in women than men. So the exposure in this setting, women compared to men, is different. And as you might expect, that's reflected in the response. So systolic and diastolic blood pressures lower in the women than the men. And then in response to that, heart rates greater in women compared to men. So whether this is simply a pharmacokinetic difference, smaller volume of distribution, smaller body weight, or whether there are other responses that are different in terms of how males and females respond to amlodipine hasn't really been answered, but what it points out is the fact that men and women are behaving differently to this drug. And the question would be, to what extent might similar things be expressed as we looked more broadly at the first step in the disposition of a drug: absorption, bioequivalence, and availability. And here are just a list of factors that may influence absorption, with some comments about how men and women, pregnant or non-pregnant, may differ. And the thing that I find impressive is, as we look through this list, men and women tend not to be the same. That's certainly not often the way that we think therapeutically or from a clinical therapeutic perspective, but it sure looks like it is different. And the question would be, to what extent is it important therapeutically? Well, another sort of look at this comes from an FDA study that was published about a decade ago, where they looked at 26 submissions for bioequivalence to compare two parameters, the maximum concentration and the exposure, the area under the concentration time curve, and asked, are there differences between men and women? So in the data sets that they had, they were able to find 26 with 47 that would allow a comparison between men and women for the maximum concentration and the area under the concentration time curve. So this is the maximum concentration, and so they're looking at the Cmax, the maximum concentration, after a single or the last dose if they were using a multiple dose schedule. And what they observed was that a quarter of the bioequivalent studies that were done, men and women were the same. So a quarter of the studies demonstrated that men and women behaved the same way in terms of the maximum concentration. Now, within the context of bioequivalent studies, generally the FDA has said that if the parameters from one formulation to the next are within 20% of each other, they're considered equivalent. Within this group of studies, 19 didn't meet the FDA's definition of being equivalent when you compare men and women. Now, if the 19 of the 47 had been comparison of formulation A to formulation B among men, they would have been rejected as not being bioequivalent. But that same kind of alert isn't raised here, where the difference is between men and women. So 3/4 of them were different in comparison, men and women. Now, women aren't always going to have larger maximum concentrations because the factors that influence volume of distribution and maximum concentration can vary both from men and women. So 3 of the 47 drugs had higher maximum concentration in men than women, although a larger proportion had a greater concentration in women. Area under the concentration time curve, or a measure of exposure. I've lost my arrow again. I'm going to need some help here. Anyone see it? Oh, here it is. I found it. Thanks. Roughly equivalent again in about a quarter. Males had greater exposure for 7 of the 47 bioequivalent studies. Females had greater area under the concentration curve for 27. 18 had more than a 20% difference. So again, just on the basis of these 2 parameters, maximum concentration and exposure, or area under the concentration time curve, which we think influences the way that response to the drug occurs, or can, are different. So that suggests, again, that even some of the initial steps in exposure between men and women are different. Distribution, well, there are a range of physiological parameters, plasma volume, body mass index, and so on, that differ between men and women, and all of these can have the potential to influence the concentration of drugs seen in a man and a female, in a male and a female. And plasma binding proteins can also differ as well between males and females. And this is just an example from a review that we did several years ago that looks at some of the compounds and how they might differ between men and women. So whether it's the plasma protein binding, free fraction, or so on. And here we've also looked where there is data at whether or not the use of oral contraceptives plays a role in changing protein binding. Elimination, focusing on metabolism. Here's another example, again, a calcium channel blocker for which there is a fair amount of data. The thing that was nice about this review by Myboom was that this particular paper compares young and old subjects by sex. And the circles are women and the triangles are men. And for both enantiomers, the thing that I think is interesting is that in general, the exposure, the concentration, the temporal pattern are greater for women than for men, even when you look at them segregated by age. Now, this is an interesting drug because of extensive first-pass metabolism, substrate both for a series of CYPs as well as the transport proteins. But the upshot is that females have a greater exposure and, much like the earlier slide, have a longer increase in heart rate than men do. So whether it's the exposure or the exposure coupled with differences in sensitivity, I think needs to be evaluated. But it does point out that as we begin to add in metabolism and transport, we're actually providing ourselves with an opportunity to think a little bit more broadly. Greenblatt and colleagues, in responding to this, pulled together 14 CYP3A4 substrates, data on clearance, and tried to focus on substrates that were not PGP substrates, looking at both intravenous or intramuscular and oral exposures or treatment. And the oral treatments are shown in the open triangles, and the intravenous or intramuscular exposures in the closed circles. What they observed in general was if men and women were the same, the female to male clearance ratios would group around 1, with more rapid clearance in the female, the exposures or symbols would be above, and for the reverse it would be below. And what they observed was that for both IM and oral treatment, in general, females had greater clearance, greater rates of clearance than males, with ratios between 1.2 or around 1.2. Well, they were also interested in trying to determine if the bioavailability influenced that, so they looked at the absolute bioavailability, knowing that there may be differences between males and females. And what they observed was that there did not appear to be a relationship between the male to female clearance ratio with respect to bioavailability of the oral dose. Again, suggesting that there are additional parameters that need to be considered in characterizing how a drug is handled by women compared to men. Hu and Zhao, a couple years ago, did the same thing, essentially conducting a meta-analysis that tried to look at sex differences in midazolam. And they pulled together the literature for both IV and oral exposures. And like these traditional plots, the symbol at the bottom summarizes the results of each of the individual studies analyzed in a collective way. So this is the clearance, and what they're suggesting is that clearance for midazolam across these studies in general was greater or higher in women compared to men, and as a consequence, the exposure was higher in men compared to women. And so this is with IV. It's a little bit less clear with oral exposures, but somewhat greater clearance following an oral exposure of midazolam in women compared to men, and a somewhat lower exposure or area under the concentration curve. When you look at all of the literature for substrates that tend to be substrates of just a single enzyme, for which transport proteins may not play a role, even within that narrow group of drugs, there's still a fair degree of heterogeneity about the size of male and female differences in how these are handled. So with a group of colleagues at SimSip, we decided to ask, could we simulate to try to understand differences in the way different substrates are handled by these group of CYP enzymes, to try to understand how would a study have to be designed, and why might we see this lack of consensus in the literature about male versus female differences. So we focused on the CYP3A4 enzymes because they're common. They're responsible for metabolism of a broad range of drugs. We know that they're more highly expressed and have greater activity and inducibility in women, so we're kind of stacking the deck. And that we had data on hepatic and intestinal enzymes. And we selected a group of drugs that were essentially 3A4 substrates, and then for the populations that we used, and you can argue about this, but this was the selection that we had at the time, North European Caucasian populations with this age range skewed to somewhat lower ages. We had equal sex ratios in the simulated PK studies, and the body composition was based on the SimSip library for this Northern European population. These were the abundance parameters that we used in the male and the female, again reflecting the somewhat greater CYP3A activity and availability in females compared to males. And then we ran a series of simulations looking at systemic clearance. And these are the 5 substrates, midazolam, which we've talked about, nifedipine, triazolam, alprazolam, and zolpidem. The literature reported clearance ratios are here, and these are the predicted based on the simulations that we did. So using the data and the simulations, the question would be, how large does a study have to be if there are differences between males and females, that you could see that difference? And the thing that I think is intriguing is if we think of most of the normal regulatory agency and support pharmacokinetic studies done in industry, typically we're going to have less than 100 individuals in those studies. And within that group then, this group of 6 different exposure scenarios, you can see that for the majority of them, or half of them at least, we would have insufficient power to be able to demonstrate a difference between males and females. Although for a small number, we would have sufficient power. So I guess one of the things that we've been thinking about as we look at these results is, does that suggest that the way that we think about the design of some of the early pharmacokinetic studies, where we're going to be using a drug, or we anticipate that the drug will be used in both men and women, needs to be changed to be able to demonstrate how big a pharmacokinetic difference there is between males and females. We do know that there are differences in renal drug clearance, both in terms of blood flow, filtration, and secretion between men and women. And while it's not completely focused on renal elimination, one of the things that I've been intrigued by are sex differences in digoxin. And what I find intriguing is, despite the fact that this is a drug that we've known for more than, and used for several hundred years, there still are interesting differences in toxicity that remain completely unexplored or poorly defined. Now, this was a really interesting study that was done by Arnouds several years ago, looking at digoxin toxicity leading to hospital admission and death in the Netherlands. And what they observed was there was about a 2 to 3-fold difference in intoxication with digoxin, despite the fact that we've known it for quite some time, between men and women. And at about the same time, Rathor and colleagues did a post hoc analysis of a study that was done to try to understand the benefit of digoxin in the treatment of heart failure. And when the study was originally designed, conducted, and analyzed, they didn't look at sex differences. And what they reported was that across the course of the study, that there was no difference between men treated with study subjects treated either with placebo or digoxin. Rathor and colleagues went back and did a post hoc analysis, so this was after the study was originally done. And they asked, well, we know that there is a potentially greater risk of digoxin toxicity in women. How does that shake out across the course of this clinical trial? And again, this was not a part of the original trial design. What they observed was that treating women with digoxin actually was disadvantageous. So the original study conclusion that there was no difference in terms of mortality using digoxin or using placebo for the study or for men was correct, but that wasn't correct for women. So using digoxin in heart failure is actually, produces a greater risk of mortality in women than men. And if you compare doses based on BMI or concentrations, they look relatively comparable between the two groups. So the question is this a pharmacodynamic factor? Are there other factors that are going on that are being expressed that put women at risk of mortality when they have heart failure and are being treated with digoxin? This is Yukawa and colleagues in Japan have done a really amazing series of studies over the past 2 decades trying to understand digoxin toxicity in elderly Japanese. And a recent study that they've done tried to look at some of the predictive factors associated with digoxin toxicity. And one of the things that I thought was interesting was that one of their predictive factors included sex. And again, with sex driving an increased risk. So all of these pharmacological components or steps or entities appear to be different to some extent between men and women. Whether that has an impact on outcome or not, we don't know. But it's one of the things that we're interested in exploring. I'm going to spend just a few minutes here with my real-life example. We've been interested in type 2 diabetes because of its public health implications, increasing numbers of individuals around the world, and because of its impact on cardiovascular disease. Individuals with type 2 diabetes have about a 2-fold greater risk of cardiovascular disease. It looks like women may have a potentially greater risk of cardiovascular disease. And in fact, the thing that I find intriguing is that the relative risk of cardiovascular death is greater in women than men, about a 50% excess, or perhaps more depending upon the way that you look at it. And I mentioned that we have available to us electronic health records, so we can look at a large group of patients with type 2 diabetes and ask, do men and women differ by the kinds of treatment that they've gotten? So I mentioned that we're using this health facts data warehouse from Cerner. Currently it contains more than 35 million patients and more than 150 million electronic medical records from more than 500 healthcare institutions. And the thing that I think is really neat about this data set is that it's essentially an electronic version of the chart. So we get not just what was done, but what the results of that were. So lab results, and we know when the labs were drawn, we know when they were reported, we know the sequence of events in terms of care, and then we can begin to look at a range of interesting questions about interactions between medications and clinical conditions. So we have an experimental type 2 diabetes data set which contains 600,000 patients. And that experimental data set then allows us to explore a series of questions like efficacy and safety. And I'm just going to comment on an efficacy component. And part of the thing that I think is really neat about type 2 diabetes is the expansion in the class of medications for treating. So we can watch new medications being introduced into treatment and see what physicians do with those new medications and what the impact on effectiveness and safety is. So knowing that cardiovascular disease is a greater risk in individuals with type 2 diabetes, and also knowing that some of these medications may also be implicated in cardiovascular toxicity, we first looked at all cardiovascular adverse events, heart failure, myocardial infarction, or those individuals that had both. And certainly there are differences in medication and condition risk ratios or risks for heart failure, myocardial infarction, or both. And if we look crudely across all of these by both male and female, they appear to be comparable. But some of these drugs also act across time, so that the risk may not necessarily accrue initially when the treatment is started, but it may occur over time as treatment continued. So we also began to look at the effect of treatment exposure years since the initiation of treatment. And so this is an example of the risk for acute myocardial infarction, where actose, Avandia, insulin, and sulfonylureas are compared to metformin. And we see some differences across time. In some instances, it may be that the treatment lowers the risk, and you'd like that actually to happen. If your treatment is effective, perhaps the risk of other conditions associated with the disease would improve. So, for example, comparing actose and metformin, we can see a decrease in risk, their odds ratio of acute myocardial infarction. Insulin versus metformin, some increase. And now, does that reflect the treatment, or does that reflect the complexity and severity of the disease? Some of those things we'll need to tease out. Well, then we separated the population by sex. And one of the things that was intriguing to us was that we see this substantial increase in risk of myocardial infarction as treatment continues in actose compared to metformin. Now, again, we typically think that treatment with metformin benefits diabetes and concomitant diseases. Does that reflect the fact that these patients are getting better and their diabetes is not as severe, or does it reflect some other factor? And the thing that was intriguing is we can't replicate that in men. So these are early experiments designed to try to understand how easily we can tease out sex differences in an adverse event that we think is associated both with the disease and with treatment. But it does suggest, I think, that we do need to give substantially greater attention and be more imaginative in the ways that we approach understanding the effectiveness and the safety of the drugs that we're using in both men and women. Thank you very much for your time and attention. I really appreciate the opportunity.